Family Trust, and I've been working as an Admiral Nurse in St Helens Merseyside area for the last 6 years. So I'm going to give you a brief overview of how I work supporting families within the area. My referrals come from a retirement trust or the beneficiaries, but I do work with all the family. It just has to be somebody who is a beneficiary for me to have a referral. Before this role, I was a registered manager of a specialist hospital for people living with dementia who couldn't be looked after in another setting. And helping families support their loved one was also a very important job as part of my role in that as well. So that's where I think I first started realising how difficult it can be to support a family when someone is living with dementia, and how important it is to provide the right support for them. With family relationships, this title covers an awful lot. Some are closer than others, but all can be affected when someone is living with dementia. And that mirrors really the latest Dementia UK campaign of that everybody's affected if somebody's living with dementia. But sometimes, do we include all the family in our support? Statutory services, social services, they're always entitled to a carer assessment, but sometimes it doesn't include all the family. So let's have a look at some of those family relationships and how many there are. So we have husbands and wives, sons, daughters. Quite often there are stepchildren if somebody's been married before, and that can sometimes cause conflict within a family. I've also looked after people who have been adopted and are looking after their adoptive parents. There's brothers and sisters, again, if they're quite elderly, they can have their own health problems. Previous wives and husbands, sometimes they step up to provide quite a caring role. So again, want to be included. Nieces, nephews, cousins. I have looked after parents as well, whose son or daughter has been diagnosed with an early onset. But let's not forget family, friends and neighbours. Quite often they're the people who may see the person living with dementia on a more regular basis than perhaps family who might live a bit of a way away. So although you have to look at confidentiality and what you can disclose or what you can provide, sometimes they need some support to carry on going in and helping the person living with dementia. So sometimes I can provide some education, some support, some tips, strategies on how to deal with if they find them on the doorstep, or if they're not sure whether it's night or day, and that can be really helpful to provide some support for somebody to carry on living in their own home for longer. Quite often with families, if someone's diagnosed with a dementia, that may be the first time that they've had to care for someone. It might be a setting that they're not familiar with. They may not know all of the resources that are out there or not out there. They may be unsure how to contact them. They may be unsure whether that would be needed at this present time, whether they think that it's not right for them, that they should carry on doing all the caring, and that asking other agencies to become involved might seem to them a bit of a failure, really, that they should be able to carry on caring as they have been doing. So my role sometimes is to let them know what those services are, what they can do, what should happen, how it might help. Certainly social services be one of the first points of call, but sometimes social services can come out and they can offer lots of things, but usually the first initial answer is no. No, I don't need that. I don't need that. No, we wouldn't like to do that. No, we wouldn't want to go. No, I don't think he'd like that. And that's sometimes an initial reaction from a carer who's frightened whether the person that they're living with would like where any respite, say, for a day centre. My role as an Admiral nurse, I'm very lucky in the fact that I have the time to talk to them on a more regular basis, to establish that rapport, to establish that trust. And sometimes it can take me 5-6 months before any help or services are brought into the family, even if people are struggling, are up at night, are finding it really difficult, if there's distressing signs and symptoms. It can take me quite a while for them to trust that what I'm suggesting is suitable for their loved one. Sometimes it's fear why people refuse any intervention. They think that people are going to come in and say, oh no, he has to go into a home, or oh no, you can't look after him, or, you know, and so they keep themselves fairly isolated, and certainly people in the 70s and 80s and 90s would not first instance call for help. They'd want to sort it out themselves. So some of the interventions and people I've contacted when I've been on some of my visits, social services, as I've said, the GP. I've worked collaboratively with the community matron and the frailty team. Sometimes the carer needs some input as well, because they're usually elderly and have been doing a very difficult job for quite a period of time. So sometimes I've liaised on behalf of the carer as well as the person living with dementia. The occupational therapist, the speech and language therapist, SALT, people sometimes don't realise that dysphagia and problems with swallowing can be a sign of dementia, a symptom with dementia. So explaining who could help and what might happen can be helpful with that. The dietitian, if we're looking at sometimes both the carer and the person living with dementia might have lost significant weight over the months where things have been difficult. Liaising with the later life and memory services can be part of my role, because they don't like bothering people sometimes, and things have changed. They've seen them at the beginning of maybe assessment and diagnosis, and then they've been discharged back to the GP. But as we know, dementia is a deteriorating condition, and when things change, sometimes their first reaction isn't to get further help. So sometimes I can liaise with that. Again, making sure that people can stay mobile, that people are able and are not at risk of falls and injury. Sometimes I can liaise with a physiotherapist, refer on. Respite is something that carers sometimes are reluctant to ask at first. I'm very lucky in the organisation I work for. We have a lovely respite home, and people can come for a couple of days, a couple of weeks, and it's a valuable facility. But not everybody wants to go straight away. Sometimes we have to introduce it a little bit. We started having lunches at the respite home so that people got used to the staff there, to realise how nice it was. Quite often, the person living with dementia and the carer come in as a couple, and they have a couple of days, and the carer gets looked after as well, and they have, you know, all the meals done and the laundry done. And then if we feel that we can support the person living with dementia, because it is a low level respite care, if we feel that can support them and then another time they can come in on their own. But actually, I have a few couples where that was the plan, but because they felt that they benefited as well, the carer benefited from that care, from having been looked after for the couple of days, they actually carry on coming in as a couple, which is lovely. I've put the police there on this list. Quite often when I do have to tell people that the police are available if they feel that they're at risk, and they can phone 999. Oh no, I'd never do that. I'd never do that with my husband or my wife. But sometimes, again, it's establishing that trust and making sure that they know what they can do to remain safe, whether that's walking out, knocking on a neighbour's door. We always make a plan if the person living with dementia sometimes gets agitated, sometimes gets annoyed, sometimes doesn't recognise the wife or husband as the wife and husband and thinks they're a stranger in the house. Sometimes it's worth making that plan when it's not in a crisis, when it's everybody's calm. We can think about what would happen, you know, if it's happened previously, what would happen in the future if that happens again. And that can help if they know that there's a plan that's been discussed and that it's okay, and that, you know, the police can be called. Also with the police, if somebody wants to go out and wanders, may get lost, then I inform them of the Herbert protocol. I can take the forms out and we can discuss how to fill it in and what it's for. The Herbert protocol, for those that don't know, is a form that you can fill in of all the things that you know about that person who may get lost, such as where they're likely to go, what they look like, any physical characteristics. You can put a recent photo on there. I always tell them to take a recent photo at the time and not use one where they've been to a wedding or gone to a ceremony, because people can sometimes look quite different. So a recent photo, where they're likely to go, and then this form is then put in a drawer. Tell them you can put it in a drawer, you can forget about it, and it's there. And then if you do need to phone the police, they've got all that information there with you, without you, when you're very in an anxious state, having to think about it. Where would they go? What would they be doing? Where they're likely to have gone? So I'm able to sit and take the time and explain that to my families, so that they know it's all there. Hearing services and vision services, these are very important for somebody with dementia. All the recent research is that if you can make sure that people can hear well, that they can see well, then it can help with them living with dementia. So we always make sure that they know how to access those services, and they've had recent ones. I do liaise with mental health services sometimes. Sometimes that's for the person with dementia, also sometimes with the carer. That may be a long-standing mental health condition that the stress of caring has exacerbated, or it could be a new condition that, because of their caring role, has brought on. Make sure that all the carers agencies in the area where I work know who I am. I always tell people who I am, and I'm the Admiral Nurse, and so they also can be helpful, because they can direct people to me, or I can direct them to those agencies, because they put on some good courses and some help for people. Looking at other charities, obviously Dementia UK, when I'm supporting people whose family may live further away, may live abroad, then the Dementia UK website is available for them. And all those leaflets that perhaps I would give out in the local area, they have access to. Also Alzheimer's, I make sure that I know what events they're doing, so I can direct people to more social events if they need it. and especially social events in the area. We do run some lovely social events with the support work. We have afternoon teas and hot pots, and we go out for trips to local hostelries, and they have a nice lunch. And the person with dementia and their loved one find them really, really supportive, because it stops that social isolation. It stops that feeling that you're the only one that having to cope with these symptoms sometimes, because they make really good relationships with the other carers as well, and they can be a support as well. So that's really good. So all these organisations can all help families. One of the things that I haven't added onto there that I do address when I go out to the visit is assistive technologies. People now quite often have a smartphone. Quite often they have the internet. They have and there are other technologies that could help, such as an Alexa or a drop-in facility, so that people who are caring for them know can talk to them without needing to have a good knowledge of technology, really, and they can drop in. So sometimes having a talk about that, what can be used, sometimes some of the GPS things that can be discussing whether that's suitable or not. Sometimes the ring doorbells and things like that can be really helpful. But they don't replace people coming in. They don't replace that contact that people with dementia and their carers need. So as an organisation, we have the social events. We also have a Meals on Wheels, and that can be an extra person going in and saying hello. And that can all help introduce if care's needed. If somebody needs care to come in, sometimes my visits, and we talk about that, maybe we've introduced a sitting service, and sometimes that gets people used to having people in the house. It can be very difficult. It can be sometimes more difficult for the carer, really, to have people in the house. I know I've had carers in as well in the home, and sometimes it can take a bit of getting used to. So sometimes my role with there is to just let them talk about how difficult it is, what we can do, maybe some strategies to make it less intrusive. So that can be helpful. I'm going to talk a little bit now about a case study of my intervention with a family who were in a very stressful situation. And it increased the carer's quality of life from my intervention. It decreased the social isolation for the family. It helped the family adjust to living with someone with dementia. It helped the daughter, who was quite a way away, to be more comfortable that there was help and support in the area if she couldn't get to her mum and dad. It also highlighted some of the challenges that I have working in the third sector, but how this can help implement good quality care in the community, in the hospital, by establishing those good liaisons with the other services that we discussed earlier. So for the subject of this case study, I'll call him Mr. A and Mrs. A, obviously for anonymity. So he's referred to me as an urgent referral. Mrs. A had read about the newly established as an Admiral Nurse service was going out. We have a newspaper, and every now and again I put a piece in, and things were getting too much for her and she couldn't carry on. He was in the process of attending the memory clinic for an assessment, and then shortly after I become involved, he was diagnosed with vascular dementia. He wasn't prescribed any medication, and he was discharged back to his GP. But Mrs. A was struggling to cope with his needs and demands and was looking for information and support. Mr. A with dementia didn't have any insight really into his memory loss, and felt he was perfectly capable of carrying on as normal, and that included driving. And that was a very difficult situation with Mrs. A when he wasn't able to drive anymore and thought that he could. And I helped her with that. His alcohol consumption also increased as he struggled to cope with his symptoms, which included experiencing quite vivid hallucinations involving seeing lots of people in the garden and children in the house. And these were very distressing symptoms for him, but also for his wife to deal with. I liaised with a number of agencies during my intervention, including the memory clinic, the GP, occupational therapy, and social services. Sometimes I had to inform the GP and social services of safeguarding risks. One concerned, and also the GP, where medication wasn't helping, and one where people was a risk to others. I advised a visit to the optician because I noticed a problem with Mr. A's eyesight, and he was later diagnosed with age-related macular degeneration. This case involved a variety of interventions: advice and support on reduced alcohol intake, information and support regarding pain control, because Mr. A had joint problems, ways of responding to and coping with changes in behaviour, coping with hallucinations and delusions, and addressing issues that could cause a risk to himself or others. I also wanted to combat the social isolation. I wanted to provide information and advice on dementia, contacting relevant services and support agencies. We spent time discussing medication and possible side effects, not only with Mr. and Mrs, but also could I also combating social isolation, but providing information and advice on dementia, contacting relevant services and support agencies, and discussing medication and possible side effects. I also provided support to the family while he was in hospital. Due to his dementia, it was difficult in hospital. He needed specialist treatment, and I was able to provide some information and support to the family. I attended a few meetings, and ultimately I provided support at end of life and following, with some bereavement support. But during my intervention, I encouraged the couple to attend the social activities, and they'd always been declined because they were anxious that because of his behaviour, because of the difficulties, that they wouldn't be accepted. So I was able to encourage them to attend, and they found these really beneficial. And I was also, while we were at some of those, it gave me the chance sometimes to talk to the carer by themselves while the person with dementia was occupied when we were doing other things. It did help an awful lot not having that social isolation, not having that loneliness. Obviously, in the last couple of years, people have been subject to that social isolation and loneliness. And I've spent the last couple of months making sure that people can get back and feel safe, getting back to some of those activities that they've enjoyed. And they're all very, very pleased that they're able to get out and about once again. As you can see from the case history, the case study, there was a beneficial impact on family life, not only between Mr. and Mrs. A, but also their daughter, who was struggling to know what was needed, what could be done in a very difficult situation. It reduced the stress felt by the wife and others. And the support that we provided was very valued by the carer. The appropriate agencies that were contacted promoted independence and minimised risks. And the family had someone to provide emotional support in those challenging situations and at the end of life. Oh, okay. But as has been shown in my case study, there are changing roles within the family, and these produce extra stresses. Maybe family members not accepting the person's illness, because again, if a son or daughter visits even on a regular basis, the person with dementia is able to keep up that social, how are you doing, how's the children, what's the matter, can I help you with this? They're able to carry on that social discourse that they've had with their sons and their daughters, and maybe they don't notice the times when it's really difficult, especially sometimes if that's at tea time, if it's sundowning or during the night. Some family members are not able to help out because of work and other responsibilities, and sometimes that can cause stresses with family members if somebody's taking the main role. There also need to be decisions about finance and care, and sometimes that can cause family disagreements. So having an Admiral nurse in to discuss that and to see everybody's point of view and to look at where there could be solutions, where there could be collaboration, can really help. When I'm visiting families, some of the common feelings that families talk to me about and that they experience, one of them is guilt. They are guilty that they're not able to keep the person living with dementia happy, settled, able to enjoy life. They feel that they may be, what else can we do? Are we doing enough? What more? And they feel guilty if sometimes they feel that they can't do it all. They can't do all the care. They do have to ask for help. They do have to have care coming in, and maybe perhaps going and living in 24/7 care. And having somebody to talk to as an Admiral nurse can help lessen that guilt. There's also grief and loss. Grief and loss of who the person was, that the person they knew, that they communicated with, they laughed with, they went on holiday with, sons and daughters were able to rely on their parents, maybe childcare, maybe do it yourself, maybe all those things that as a family we all have our roles, don't we? And the grief and loss of those of that it can be quite hard to bear for families. So sometimes being able to explore that with an Admiral nurse can help. People also become quite angry that the plans that they had, the future that they were looking forward to, that they'd retired and they were going to enjoy those years, is now not going to happen. Especially you know, being able to take part in family ceremonies sometimes, or finding it difficult to get away, to have some time to themselves. Sometimes carers feel very angry that they're not able to do maybe some of the hobbies, some of the leisure activities that they were used to doing. And then they find that they have to, not being able to do those activities then leads to loneliness and isolation. And that can be very hard for sorry, people who have been active and out. When we look at chronic stress and anxiety, people become very anxious. that everything's okay, that they're looking after them, they haven't missed anything. They're always saying, well, you know, even if sleep is disturbed, but even if they go to sleep, they'll use it, explain that they've got one eye open, that they're listening for what the person living with dementia is doing, what he might be doing next. And this constant being on guard can have a detrimental effect on people's mental health and also on their physical health. And sometimes those needs aren't addressed. And sometimes you will find the carers self-neglect, and they feel that they're neglecting others, whether that's their sons, daughters, other family, friends. And it's important to talk to the carer and find out what they would like to do, where they would like some time, where they would like some rest, and try and facilitate that. Because any respite, any time where you're looking after yourself, being kind to yourself, being able to do something for yourself is very valuable when you're spending 24/7 looking after somebody. I'd like to thank you for listening. I hope I've helped and told you a bit about my role and some of the things that I can do. Thank you.